All right, let's look at a few more questions here. Some of the joints here. So we're going to look at some of the joints of the lower extremities that are holding the limb in place, securing all the different bones together. And then we'll talk about some of the tendons that help to secure those joints. Starting with the sacroiliac joint, this is between the sacrum and the ilium, sacroiliac joint. It's a strong weight-bearing joint, okay? It's going to be partially a synovial and then partially a syndesmosis. So posteriorly, syndesmosis means that it's not necessarily articulating where we have a synovial cavity. We have a fluid-lined cavity and we have mobility. So posteriorly, there's no mobility between the sacrum and the ilium, right? It's secured, it's fixed, it's more of a syndesmosis joint. Whereas a part of it anteriorly has a little bit more movement, flexibility, mobility, especially in the female pelvis, you will see. Now, the auricular surfaces of the pelvis and the sacrum are going to come together to form this joint. And this is very limited mobility, as I mentioned, right? It's more for security, more for stability, more for structural support than anything else. But a little bit of flexibility is important as well. Let's look at the hip joint itself. The true hip joint is the ball and socket joint, the synovial joint between the head of the femur and the acetabulum of the hip bone. Remember, acetabulum is a shared feature comprised of the ilium, ischium, and then part of the pubis as well. So it's a shared structure and it fits the head of the femur to create that movable synovial ball and socket joint. It's designed for stability over a lot of movement. Unlike what we see at the shoulder joint can give us a lot more range of motion. This is why it's a little bit less stable, more unstable, more likely to see dislocations, and so forth. Hip joint, a little bit less mobility, more structural stability. The hip joint is going to be secured by a few ligaments. The iliofemoral ligament is the Y-shaped ligament that helps to anchor the true hip joint, so the ball and socket joint here. And so that is going to be a strong ligament that prevents hyperextension, especially when we're in the standing position, the erect position. So it's Y-shaped, as you can see, the fibers running down, but also across onto the greater trochanter from the ilium to the femur, hence the iliofemoral. Another portion of securing that same joint is the pubofemoral ligament, okay? This is running from more of the pubis, the ramus of the pubis, across onto the femur as well, and then also blending with the fibers of iliofemoral and preventing excessive abduction, right? Preventing excessive movement of the hip away from the midline, which can certainly disrupt that joint. So iliofemoral, more lateral, Y-shaped, pubofemoral, more medial, more anterior, and then blending with the fibers of iliofemoral. Next, we have ischiofemoral. Now, we're going to have to look at a posterior view in order to appreciate the ischiofemoral. This is the weakest of the three, most commonly involved in things like injuries and tears. So that the posterior aspect here is a little bit more vulnerable. But this is running from the ischium kind of twisting across to also emerge into the fibers of iliofemoral and then attach onto the femur. All right, let's move down to the knee joint. And the knee joint is probably my favorite part of the anatomy of the body. It's a really complex joint, unlike any of the other joints in the body, including the elbow joint. The knee joint has a medial condyle and a lateral condyle of the femur and the tibia that both articulate together. So medial lateral condyle of femur, medial lateral condyle of tibia articulate together to create. Now, it's not a flush, smooth articulation, which is what adds to the complexity of this joint. It's more of kind of an unstable articulation, which tells us we need a lot of ligaments to secure this, right? Now, because of the types of actions that we do need at the knee joint, a lot of flexion and extension, and securing most of the weight of the body, this makes the joint vulnerable to all types of injuries, especially in contact sports. Football players, hockey players are going to have, have higher vulnerability, higher likelihood of injury to the knee joint, especially with injuries that are going to be more horizontal, lateral blows, medial blows. They can certainly disrupt the ligaments that secure the joint. We also want to remind ourselves the fibula is not involved here, which again is another difference between the elbow joint where we have both the radius and ulna articulating with the humerus. Here, it's only the tibia articulating with the femur. However, some of the ligaments that we'll talk about will attach to the head of the fibula just in effort to secure those structures together. But the true articulation does not include head of the fibula. Now, some of the ligaments that I mentioned here would be the lateral collateral ligament. So here's a lateral view, here's a medial view, and we can see the lateral collateral ligament going from the femur to the fibula to secure the joint laterally. If we look at the medial aspect, it's a much thicker band or thicker ligament articulating the medial aspect, which is the medial collateral ligament, going from the tibia this time to the femur. And then we have the cruciate ligaments. The cruciate ligaments are internal ligaments, so they're deep within the condyles of the femur and the tibia, and they cross each other, hence the term cruciate. Okay, the anterior cruciate ligament, best seen from an anterior view, goes from the anterior condyle of the tibia, right, to the lateral condyle of the femur. So anterior condyle of the tibia to the lateral condyle of the femur. So it kind of goes posterior laterally from the anterior medial to the posterior lateral, crossing anterior to the other posterior cruciate ligament. It's the weaker of the two. And then we have so that means it's most likely to get injured. So you're most likely to see ACL tears as a part of those contact sport injuries that we talked about earlier. The posterior ligament is going to be crossing on a posterior aspect, going from the posterior condyle of tibia onto the medial condyle of femur, again, going from a anterior lateral perspective to a posterior medial perspective, right? Crossing behind the anterior cruciate. It's going to be the stronger of the two, so we're going to see less tears here, more posterior reinforcement of the knee joint. Now, just to talk about how these ligaments might get injured, anterior cruciate ligament might get injured with a twisting injury. You see this a lot with soccer players. You know, they're trying to do a weird move, they twist, the femur goes one way, tibia goes one way, and the ACL is gone, right? Another type of injury we might see that injures the posterior cruciate this time is a hyperflexion injury. So a dashboard injury, someone gets into an accident, their knees hit the dashboard, that causes the joint to go into hyperflexion, and then that would injure the otherwise normally secure posterior cruciate ligament. So very vulnerable joint. You can see a lot of injuries here and a lot of different types of actions. Let's get to the menisci. The menisci are also vulnerable to injury because they are attached to some of the ligaments, as we can see. Now, the menisci are fibrocartilage and not actually ligaments like the other structures, but they do act in a similar way to secure and protect the joint. These are kind of discs, articular discs that sit in the condyles and that help to absorb shock, deepen the surface to create a smoother groove. We talked about how the femur and tibia don't create a flush articulation. It's not smooth. They don't sit against each other, kind of the way the elbow does with the trochlea sitting very nicely to create the elbow joint. Here, it's a much rougher articulation. So the menisci help to create kind of the surface that allows this to be a better articulation. And it also helps to absorb shock, which is a huge part of the role of the knee joint. Okay, absorbing shock, stabilizing the rest of the weight bearing of the body. So the medial meniscus is a C-shaped, kind of discontinued sort of fibrocartilage pad here. The lateral meniscus, however, is much more continuous, almost a circular shaped pad. The medial meniscus is attached to the medial collateral ligament, which we talked about earlier. Therefore, we're more likely to see these three structures get injured together: the ACL, the medial meniscus, and the medial collateral. So when we talk about those twisting injuries, we usually see all three of these structures injured together. This is actually called the unhappy triad, right? The unhappy triad, or the O'Donoghue's triad, where we usually don't see these structures injured separately. It's usually one action injuring all three. Let's look at the ankle joint. This is the talocrural joint. This is a hinge synovial joint between the tibia, distal end of the tibia, and the talus at the ankle joint. So this is, again, a very secure joint, only allowing flexion extension, not much of any other motion or movement, but it is a synovial joint. And we can see things like eversion injuries, inversion injuries when you sprain some of the ligaments as well. If you happen to have, a fall onto your lateral foot or anything like that. And then some of the distal joints here, the metatarsophalangeal joints between the metatarsals and the phalanges. So here's the metatarsophalangeal, here are tarsals, here are phalanges. And then we have the proximal interphalangeal joint between the proximal phalange and middle phalange, except the great toe. At the great toe, the proximal phalange is between the proximal and distal. And then the distal interphalangeal joint is between the lateral 4 digits, between the middle phalange and the distal phalange. Very similar to what we see in the phalanges of the hand. Okay, let's wrap up with a few questions, a few final questions.